Welcome to another episode of Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzal.
So today's episode is slightly different. On our YouTube channel, we've been getting a lot of comments, and we try to answer the questions as much as we can within the limits of the site itself, but also to our email address. More and more people have been sending videos and x-rays of their specific injuries. So today is a case study of one of those exact cases.
I find this really cool.
Yeah, it's super cool.
I have like an engineering background, so to be able to see the mechanism of injury and then know the injury is really exciting. And maybe it's just me, but I love that stuff.
I just like to see people fall down.
He like fails.
Yeah.
Okay, so let's cue the first video.
Okay.
This is a
10-year-old boy.
10-year-old boy just skiing with his dad, or he's snowboarding, his dad's skiing, filming him. And you can see how he takes a fall there and spins around.
And which is very common in snowboarding. Lots of people fall and don't actually have injuries, but this is not the case here.
Exactly. So what do you think he injured?
I think he broke his coccyx.
People don't know what a coccyx is.
It's like your tailbone.
Yeah, no, he didn't. He had a twisting injury to his tibia. So I happen to have a tibia right here. This is a tibia, not a real one. This is a plastic sawbone one. This is the tibial plateau, the top of the tibia. This is the bottom of the tibia known as the tibial plafond. This part makes up the knee. This part makes up the ankle. So if you can imagine, the foot that's attached here is strapped into a long snowboard, and this part here is attached to his body. So his body turned one way and the snowboard spun around the other way. So what do you think is going to happen if I put a torque on this tibia?
Usually torsional forces result in spiral fractures.
I'm trying to break it right now.
Yeah, don't try to break it.
It's not happening.
So you end up with a spiral fracture of the mid-shaft of his tibia.
Yeah, and I kind of drew one on here. I don't know if you can see it. It's basically a line obliquely comes down and spins around right around the tibia. So you just as if you twisted this and it has a little spiral and it breaks apart. So this part of the tibia is not connected to this part of the tibia anymore. I had a patient once who broke their tibia when I was a resident. I said, oh, you know, it's like a 6-year-old. I said, you got a broken tibia. Your leg's broken. And he looks at me and says, forever?
What did you say?
I said, yeah.
Yeah, forever?
No, not forever. It's going to heal, especially in kids, it's going to heal.
That's what's great about kids. So kids have a very thick lining called periosteum along their bones. And what it does a couple different things. One, it prevents them from grossly displacing when they're broken. So I always tell my patients in the fracture clinic that kids' bones break like a green tree when it kind of bends, but it doesn't really break. Whereas older people that are in their late 20s, like Paul and I, break like dry old pieces of wood and they splinter. So kids' bones stay together. So that spiral fracture, it'll minimally displace, but typically not completely displace.
Right. Okay, so there he is on the hill. He says his leg hurts, can't stand on it. What's gonna happen to him?
He gets the toboggan ride of shame down the hill. So he gets the free ride.
Free ride down the hill.
To the ambulance, over to the local emergency room.
Right. First thing that you should do if you ever stumble upon someone like this is splint that leg, because the tibia is now in 2 pieces and it hurts a lot when the 2 pieces of bone move. So the first thing you can do, just be kind and splint it. So however you can. Wrap anything around it so it doesn't move around as much.
Some people even use ski poles and scarf. I've seen that before. So anything to keep it straight, that's going to reduce the pain. Get them so that they get that first x-ray.
Right, so they get down, they see an emergency room physician eventually who does a history, asks what happened, does a physical examination.
Make sure the bone's not sticking through the skin or a compound or open fracture.
Right, those need surgery right away. If the bone's sticking through the skin, that means bone has seen the environment. It might be at risk for infection, so you go right to the operating room and wash that out.
Okay.
So this one, fortunately, from what I understand, was not open.
Yep.
So x-rays were done, and let's take a look at the x-rays.
Okay, so the first x-ray, they always do at least 2, so 90 degrees to each other, so they have an AP or an anterior to posterior view, front to back.
Looking at it from front to back.
And then what's called a lateral view, or an x-ray from the side.
One side to the other.
And the reason that we do that is because sometimes you actually can't see it on one view and you can see it on the other. So on the AP view here, it actually is not particularly impressive. You might even miss a fracture if you only looked at this view.
Yeah, this is a good example of how you could actually miss a fracture if you just looked at the AP view.
Okay, and then on the lateral?
There it is. Can't miss that fracture. You can see the line through the middle of the tibia, and it's basically showing that, hey, this bone is broken.
Yep. Okay, so now what? So you got a broken tibia, mid-shaft tibia. Oh, the other thing on the x-ray that you can see is those little lines at the top and the bottom of the bone. Those are his growth plates, and that represents cartilage. So it's a different density on the x-ray, and that's what allows our bones to get longer.
This bone is pretty well lined up in these x-rays. What happens if it's maybe not lined up totally? In this case, in this 10-year-old boy, it's a little bit angled. Are you gonna freak out? Are you worried?
So hopefully I don't freak out because I have a 10-year-old boy.
I've seen you freak out.
Yeah. So if it's a small amount, then I'm not particularly worried about it because younger bones are very forgiving and they can remodel over time. If the angulation is greater than 15 or 20 or 30 degrees, then we would probably do something to try to correct it, either with the cast that we're going to put on or potentially taking them to the operating room and just gently setting it back in place.
It's called reducing the fracture. We try and get it lined up as best as we can, but it does not have to be lined up perfectly because the kid's bone is growing, so it will to a certain degree straighten itself out, although this one is well lined up. Okay, so we talked about casting. Now the thing about this cast, can I just put a cast from like the foot up to the knee in this guy?
You could, just probably wouldn't work very well because you need to control rotation.
Right, so if the cast ends below the knee, the tibia can still rotate in the cast, and you can end up, the fracture could heal rotated where he's looking north and his foot's pointing east. Nobody's happy with that.
No, or he's walking in a circle all the time.
All the time, never get to school.
No.
So we have to take that cast above the knee, right up into the thigh.
Do people like above knee casts?
Nobody likes an above knee cast.
Because it's hard for the parents, it's hard for the kid, and it's heavy. It's a lot of cast material. So you can't bend your knee, you can't walk on it, you can't get on and off the toilet without much difficulty. It's really complicated.
But you can still go to school. It's a lose-lose situation for a kid, it really is. So you got the above knee cast, that's on there. You gonna keep that on for 6 months?
No, probably 4 weeks would be my ballpark. I'd follow them with an x-ray and try to assess maintenance of alignment as well as evidence of healing. And normally in an adult at 4 weeks, you don't see any evidence of bone on an x-ray a lot of time, but at 4 weeks in a kid, you're gonna see evidence of bone on the new x-ray.
Yeah, and it's gonna get a little sticky in there, so I'm not gonna be so worried about it rotating, so I can take that cast down below the knee.
Yep.
I do that for another 2 weeks, and then I let him start walking on it. And usually I'll put him in like a boot type device, an air cast boot of some kind, that lets them put weight on it and actually walk on it in that boot for a little while.
Yeah, it's good for it. It stimulates the bone. Often they can get rid of the crutches then, start to resume a little bit of more normal activity, maintain some of their muscle mass in their quads, not necessarily in their calf.
And the other cool thing about bone is it likes to be loaded. So if you have a fracture and you can control rotation and not let things bend too much, if you put a load on it, bone actually likes that and it responds to that by healing and making more bone.
Yeah, good. So say you get to the 10 or 12 week mark, you've got an x-ray that shows there's lots of bone.
Let's look at the x-ray.
Okay.
So here's the AP view.
Yeah, which looked perfect before.
Yeah, it still looks good.
Still looks good.
And on the lateral view where we really saw that fracture, you can see that the fracture is becoming more and more difficult to view, to see, indicating that bone is going across the fracture and it's actually healing.
And yeah, so what happens is when you break your leg, you get blood there, and then that blood becomes like a scar tissue kind of gristle material, and then that slowly gets converted over to bone. So originally you can't see it on x-ray, and as it becomes more bony, that's what fills in that black gap.
We're always taught in medical school and residency, don't treat the x-ray. So if you just see that, are you saying, okay, it's healed just based on the x-ray?
So no, because I went to the same medical school.
That's right. We both learned. We look for evidence, clinical and radiologic evidence of healing. So that's radiologic evidence of healing. Clinical evidence of healing is if I palpate or feel the tibia, feel the patient's leg and push around where the fracture was. That would be a cruel thing to do in day one after the fracture, but after close to 3 months, it shouldn't hurt anymore. And usually it doesn't. They say it feels good.
And especially at 10, they're racing around, the parents are concerned, they tell you that unbeknownst to them, they've been on a trampoline or were playing around in the schoolyard. They certainly don't honor the limits that you put on them.
Yeah, kids get back to it.
Yeah.
So now we're around, with that x-ray, almost 3 months, so he probably got his cast taken off, his boot taken off, and he's gradually getting back. Is he gonna be able to ski again?
So eventually he'd be able to ski or snowboard. I tell people that you want to gradually return to your normal activity. You may or may not do some physiotherapy on your own, but really being 10 years old is kind of ongoing physiotherapy. And then, another 4 to 6 weeks maybe, and then back to high impact sports if they wanted to.
Kids don't need a ton of physiotherapy. They usually get back to it pretty good. If I have a young athlete, a very competitive athlete, and getting back to sport is key for the parents usually, then I will do some physiotherapy, some sort of sports-specific physio to get them back to it. But for the most part, the average recreational child doesn't need a ton of physiotherapy, unlike someone like us who breaks their tibia. That would take intensive physiotherapy and psychotherapy for years before we get back to it. But for kids, they bounce back pretty quick.
Very interesting case. So if our viewers have any other cases like this, if you have a video of your injury as well as a diagnosis, please send it to us at info@talkingwithdocs.com and we'll do our best to respond.
Oh yeah, we won't make fun of you. We'll just show the video and discuss the case.
Absolutely. And if you like this video, please like it on YouTube or subscribe to our channel.
And remember, you are in charge of your own health.
See you next time.
I really tried to break this thing.
I know you did.